Member of the International Diabetes Federation and chair-elect for Southeast Asian Federation. He would be discussing with us on navigating the hypertension-diabetes nexus, best practices for clinicians. It is an honor to have you with us on the platform today, sir, and over to you for the presentation.
Thank you, Dr. Gulshan. Thank you, Manish and technical support team of Sprint. And I'm thanking Indian Society of Hypertension for giving me this wonderful opportunity. What I'm going to do in next half an hour, let me share the slide first. Can you see the slide?
Yes, sir, they are visible.
Good. So now, in next 30 minutes, I'm going to talk on a very important topic. And then, the best practices for clinician. So let me start with the first slide, that we know that hypertension and diabetes, it's like a deadly duo. It's really dangerous to have both the disease together, and that increases the cardiovascular risk by threefold. Hypertension alone is associated with 57% increase in all-cause mortality in persons with diabetes. So one comorbidity in diabetic patients with hypertension increases further their all-cause mortality by 57%. What I am going to do in next 30 minutes, first I will be talking hypertension in patients with diabetes, how we should monitor blood pressure in persons with diabetes, what is recommendation by various organizations, and then we will summarize our talk. This is the prevalence. Hypertension is a major public health issue in our country. If I see, it is responsible for 10.8% of total mortalities and 4.6 years of disability adjusted life years. Prevalence of hypertension is actually higher in patients with diabetes. 50% of cases of hypertension also being diagnosed with type 2 diabetes. Prevalence of hypertension is nearly double in persons with diabetes, those who are without diabetes, and risk is more marked in elderly people. Coexistence of diabetes and hypertension, which is actually increasing in our country, and I will say it is increasing day by day in our country. The relationship between hypertension and diabetes, both are because of metabolic syndrome. It is the sympathetic nervous system, it is increasing arterial stiffness and the microvascular damage, which is responsible cause for hypertension. And the diabetic people also have the obesity, insulin resistance, increased reactive oxidative stress, reactive RAS system, increasing sympathetic nervous system, altered renal sodium handling, altered immune response, and increased inflammation, which is actually a part of metabolic syndrome and which is responsible cause for hypertension and diabetes both. But at the same time, those who have hypertension, it further because of antihypertensive drug and a nephroparenchymal hypertension increases the further risk of diabetes too. So this complex cause-effect relationship between hypertension and diabetes involves obesity, visceral adiposity, and insulin resistance is the main pathogenic factor. Diabetes and hypertension, they predispose to people with cardiovascular disease because both these disease increases the risk of heart disease because of atherosclerosis, more of a endothelial dysfunction, more of a vascular inflammation, more vascular fibrosis, and arterial remodeling. And this is responsible cause for micro and macrovascular disease both. There are some common risk factors, as I already told you, which is a metabolic syndrome, a insulin resistance syndrome with dyslipidemia and obesity, which are important reason for them. And there are some genetic factors which are also responsible. Hypertension and diabetes, if I see globally, diabetes may be 300 million people, but hypertension people will be double of this. Projected people in 2030, it may be 450 million around, and this will be 1.56 billion. It means every 6th or 7th person in the world will have hypertension, and increases micro, macro, peripheral vascular disease, and even brain also disease. The stroke also increases because of hypertension, and with diabetes, it further increases the risk of stroke and other disease too. How we should manage? Managing hypertension in patients with diabetes lowers the risk of ASCVD. So we should decrease the blood pressure in persons with diabetes because not only heart disease, but kidney problem also decrease with the control of blood pressure in persons with diabetes. Every 10 millimeter of Hg decrease in systolic blood pressure is associated with risk reduction of 12% reduction in complication, 15% of reduction in mortality, 13% reduction in microvascular complication, and 11% reduction in risk of myocardial infarction. So a good blood pressure management in people with diabetes significantly reduces the risk of cardiovascular complication. Diagnosis. Now, when you should say, what is the diagnosis? Now, there is some gap in international consensus. The ESC and ESH, slightly, they are more liberal to keep the blood pressure target less than 140/90, but recently ACC and AHA, they say that more than 130/80, you should be cautious to treat them. They are like a pre-hypertension or a people whose blood pressure is likely to increase sometime, and they should be treated for that. They are also trying to keep the target blood pressure, you should try to keep less than 120/80. They have kept the stage also 1 and 2, while the people with ESC, ESS, they say that grade 3 hypertension, which is not there by ACC, they are saying it is more than 180/110. The age-specific blood pressure criteria is only given by the ESC, while the ACC is very clear. They all should maintain less than 130/80. So there is some gap, but Indian Society of Hypertension is exactly, we are more moderate and somewhere we are more aggressive too. The diagnosis, as I told you, the grade 1 hypertension is more than 140/159, while high normal blood pressure is considered when the systolic is 130 to 139, while diastolic 85 to 89. So the recommended cutoff for diagnosis is 140/90, while recommended cutoff for target blood pressure is 130/85. So I mean, that is what the target blood pressure which I would like to keep for my patient, less than 130/85. The recommended methods of blood pressure measurement. Now, the clinic measurement, the home blood pressure, and ambulatory. These are the 3 standard way of blood pressure monitoring. Ideally is clinic measurement. Home BP monitoring, we are promoting in India. We say that everyone should have one home blood pressure monitoring instrument. Occasionally, when we suspect masked hypertension, when we suspect white coat hypertension, when we suspect a lot of fluctuation in blood pressure, then even ambulatory blood pressure monitoring is also recommended. This is something very interesting slide. Why we treat diabetic patients? To reduce the complication. So simple is, one side you control the glucose, other side you use the molecule which can help to reduce the cardiovascular and kidney benefit. But in between, the 2 more important things which we should not forget, a diabetic patients may have blood pressure and lipid, and these 2 are to be monitored, these 2 are to be treated, and they should achieve a tight glycemic control along with tight blood pressure control and with good lipid control, also with the LDL cholesterol less than 70 if they are high risk, or less than 100 if they are not very high risk for cardiovascular disease. But to my surprise, and I'm sure all of you will agree, that in 2005, there was one paper which was published to show that 85% of the people, they are not having good control of blood pressure. It means so easy to give them therapy, but still they are not keeping. And only 3% are actually having a tight BP control, tight blood pressure is under control. That is only 3%. Today, slightly scenario after 20 years, I can say it may have improved, but still the data shows that around 50 to 60% are still not under good control as long as diabetic persons are concerned, when their blood pressure target is to be achieved. Ambulatory blood pressure is recommended. People with diabetes and hypertension, particularly risk of post-treatment complication, overall improvement in blood pressure. It is recommended to opt for standing position. Calibration and validation of BP measurement instrument must be considered. BP must be monitored at every office visit. It's a vital sign. In patients with elevated blood pressure, a multiple reading must be taken for diagnosis of hypertension. But are we looking for a masked hypertension? We are worried sometimes that a person may have a blood pressure which may be normal, but actually in between they may have higher blood pressure. They are completely masked. And that's where we have to ask the persons for a home blood pressure monitoring, and where we have to ask the person for ambulatory blood pressure monitoring too. Now, once we start the treatment, I'm sure all of you will agree that we have to go for a dietary and a lifestyle recommendation, whether it's a plain hypertension or hypertension with a person with diabetes. So, I mean, with a person with diabetes, they are already on a dietary and nutrition counseling, but they should be given a combination of dietary and lifestyle intervention. And nutrition education is very important. The obesity itself is risk for hypertension, and anything which is you are supplying extra calorie, which will increase calorie balance, which will increase the risk of blood and overweight or weight, that will also increase the risk of hypertension too. So the physical activity and some muscular exercise with a good dietary recommendation, which will reduce the calorie intake along with low sodium diet, will definitely help the people with hypertension. What's the pharmacotherapeutic agents which we can use? Individualized profile. I mean, that's very important. It means not every patient is to be given in the same way, but combination of ARB and CCB, which is indicated in many of our patients for better readiness because of one drug. ARB either with BP or can be used in BP control in diabetes patient. So the choice of therapy for the diabetic patients definitely goes with ARB. In patients at the risk of CVD, renal disorder, cerebrovascular disorder, combination therapy must be preferred for the reduction of patient mortality. CCB must be preferred over beta blocker, thiazides in combination therapy with ARB. The use of beta blocker and thiazide diuretic must be avoided in patients with diabetes, hypertension because of their potential to cause CV events, hyperglycemia, and respectively. And that's the reason thiazide diuretic in persons with diabetes naturally less. But beta blocker, we had to use some time to maintain the blood pressure along with a high pulse rate, which they may have. Monitoring of electrolyte level, particularly potassium, creatinine value, regular monitoring for kidney functions. They are very, very important when we are putting them on a Doppler, getting the renal Doppler and all those things, and plus renal function test. What are the key guidelines? So if I go with the hypertension guideline, EDA, ESC, ISH, KDIGO 2020 and 21. The almost all guidelines are saying that ACE or ARB are the choice of therapy. The second line, definitely CCB, almost everyone is saying. So, I mean, there is no doubt about the ACE and ARB. Points come with the diuretic or beta blocker. Sometimes with a patient with coronary artery disease, beta blocker may be choice. With the patient who is non-diabetic, ARB, I mean, a thiazide type diuretic may be a choice for that. ARB helps to reduce the risk of CV events, cerebrovascular events, and renal complications. We have on-target data. So now any antihypertensive therapy which we give, primarily we have to say that this molecule should reduce the CV events, cerebrovascular events, and renal events, all three, which are very, very important in a person with diabetes. And normal society also person have a lot of CV events, cerebrovascular event, and renal complication also. So SC inhibitor may be preferred as a first-line therapy. Both these agents effectively reduce the CVD in high-risk patient, and both ARB and SC inhibitor effectively reduce the risk of end-stage renal disease. So you can give even ARB also with AC inhibitor, but that's normally we don't give it, but they are or we should give them. ARB are administered in combination with other agents like CCB and diagetic, which is very common in our country. Telmisartan, losartan are most effective choice. Telmisartan is the first choice of therapy. In those at a high risk of stroke, losartan must be preferred where telmisartan is recommended in patients having history of atrial fibrillation. Now, the new molecule, eslisartan, it improved diastolic function of left ventricle in patient with heart failure with preserved ejection fraction, also is a suitable agent for hypertension control in CKD patients. When you will use the beta blocker, if history of myocardial infarction, heart disease, coronary artery disease, stable angina, then they are the choice of patients for beta blocker. But there is a risk of using beta blocker because it may increase the hypoglycemic state, risk of CV events in patients with diabetes, and not recommended unless absolutely indicated. Calcium channel blocker, widely first line, expert potent antihypertensive agent, more pronounced effective effect on stroke, significant reduction in risk of coronary events, and reduces cardiovascular mortality and morbidity. So the novel CCB are preferred due to their able added pleiotropic benefits other than antihypertensive agent. The CCB like newer are, we know that cilnidipine or felodipine, or these are the molecules, benodipine, they can be used also. The role of Cilnidipine, because it decreases heart rate, it is uricosuric agent, it has greater tolerability, it has must be preferred in patients with proteinuria or pedal edema, and it's renoprotective, it is cardioprotective, it is increases insulin sensitivity and a better safety profile too. But at the same time, it controls good blood pressure too. Diuretics are now commonly not used for managing diabetes and hypertension. In patients with diabetic hypertension, because of its potential or elevated fasting blood glucose and HbA1c level, so hydrochlorothiazide is not used. And low dose aldactone, spironolactone can be given if blood potassium level is less than 4.5. If your patient is having stroke or TIA, 28% chance they are going to have. Diabetes, 90% chance. Hypertension, 30% CV event. Hypertension more than 70 years, 28. Hypertension, 27. Older with hypertension, idiopathic systolic hypertension, 37% CV events. Older with idiopathic systolic hypertension, they have increased 36% stroke. Old hypertensive, 40% increase CV events, and older with ISH is 14% reduction in blood pressure too. This is the algorithm which is given by ADA, that initial blood pressure more than this, start 1 is it, initial blood pressure very high, start 2. Albuminuria or CKD, definitely ACE inhibitor, start 1, other drug could be CCB. Albuminuria with CKD, start during therapy only now AS, ARB, CCB diuretic, that is what we do. Or otherwise start ACE or ARB with CCB with diuretic. This is what is recommended by American Diabetic Association. We have to do very individualize the therapy. It's not like that all the patients are to be treated in the same way. The patient who is having heart failure, definitely we have data to support that these are the patients who should get more benefit because of beta blocker. The patient who have post-myocardial infarction, I think ACE inhibitor, there is no doubt about it. The ALA, high coronary artery disease risk factor, then you have to think of something like life and hope. The molecule which has now convinced us that that should be used in people with high cardiac coronary risk score. Diabetic patient definitely are NCAF, ADA guideline, UKPDS, and LART guidelines. Chronic kidney disease, and then they have a diabetes guideline for KDIGO and renal and irbesartan, renin, and ARS therapy. Also, these are some of the guidelines. So the summary of recommendation is definitely ACE, ARB, CCB can be given diuretic. Yes, no. ARB, telmisartan, agilsartan, ACE inhibitor, preferably my preference will be always for the molecule which is once in a day, which we give it regularly to our patients like ramipril, or it can be given along with CCB. CCB or cilnidipine or amlodipine. Diuretic is used in case with resistant hypertension. When you are having more than 3 drugs already, ACE, CCB, and you had used beta blocker 2, still not controlled, then probably a diuretic can be choice. And this individualizing means, the first we should explain the patient, shared decision-making process. We have to address the cardiovascular risk, 10 years risk also we have to calculate. Potential adverse effect of the medication should also understand, and the patient preference, where to buy, what to buy. Is it the Pradhan Mantri Yojana molecule is good enough or not? Those old questions will be there. If someone at higher risk, keep the blood pressure of 130 by 80. But if they are normal risk, then probably you can keep less than 140, 92. One should not overlook the potential adverse event of antihypertensive medication. This, I thought, will be very, very important, because we start the therapy, but we forget hypertension, hypotension, syncope, fall, acute kidney disease, electrolyte imbalance, older age, CKD and Italy, frail. Patient becomes very frail. Orthostatic hypertension can happen, so you should check the blood pressure while standing too. In ACCORD BP, it was found that intensive blood pressure lowering decrease risk actually it increases the cardiovascular events. Therefore, presence of low blood pressure systolic is not necessarily contraindicated to more intensive blood pressure management in the context of other standard care. So, I mean, a patient's systolic blood pressure may be slightly high, try to treat it. If it goes slightly more diuretic or more diastolic blood pressure will decrease, there won't be any problem for that. A combination of ACE or angiotensin risk blocker should not be used. If one class is tolerated, don't substitute to other drugs. That's very, very important. In patient receiving ACE or ARB, Continuation of these medication can be continued till eGFR become less than 30. In the absence of albuminuria, risk of progressive kidney disease is low, and ACE or ARB have not found to afford superior cardioprotection. So if somebody already kidney failure with less than 20 or 15, probably then ACE or ARB to be stopped. Beta blockers are indicated in setting of private MI, active angina, prior MI, active angina, or heart failure with reduced ejection fraction, but have not been shown to reduce mortality as blood pressure lowering agent in the absence of these conditions. The bedtime dosing. Although prior analysis of randomized control trial found a benefits to evening versus morning dose of antihypertensive agent, but these results have not been reproduced in subsequent trials. Therefore, patient preferential use of bedtime medication is not recommended, but we give it after breakfast or at bedtime only. What's when you will call resistant hypertension? When you have triple drug already and still they are keeping their blood pressure more than 140 by 90. These are the people who are triple drug therapy on resistant hypertension. We should add diuretic in these patients. That's most important. C4 hyperkalemia and all this factor for them. What should be the approach? Improve patient level adherence, reduce pill burden, and use once daily injection. So don't give morning, evening, multiple doses. Also, lifestyle with home blood pressure monitoring, with regular walk, yoga, and exercise will definitely improve the quality of life, and keep at one place at least your all electronic medical records too. What will be happen with pharmacy and out of clinic? The patients who will go to these people to talk to the doctor, so they use it as a hub model for contacting their consultant too. With this, I thank once again, thanks to Indian Society of Hypertension for giving me this wonderful opportunity to discuss with you. If I have any question, please let me know. I will be very happy to answer for those.
Yeah. Thank you, sir. That was a really enlightening talk and a very complex matter. And every doctor obviously faces these situations day in and day out. So we have lots of questions related to this. We'll try to take up as many as possible. And many of these are related to many of the modern newer drugs that have been put in the market. So one of the questions that we started with, you said that uh, there is something of a concept of masked hypertension. The patient comes to the clinic, but his blood pressure BP is normal. So how do we identify such patients? What are there any indicators which would force us to suspect a masked hypertension?
No, so masked hypertension, there could be, these type of the patient actually should be asked for a home blood pressure monitoring. The persons who have already more than 11380, they are already at the risk of them. Then these who are already patient with a diabetes, with kidney problem, their blood pressure should be strictly monitored and measured. So these are the some of the very important points which I think I have covered in my talk also, but they are very, very important.
Right, sir. So now with the advent of newer drugs like SLGD or SLGT2 inhibitors, which have also shown some renoprotective and cardioprotective effect also. So
Yes.
how do they figure in the management cascade? Now, as you said that ARBs are the first line. When do we figure out that, okay, obviously they are added to control blood sugar, but does that make any change in the terms of giving the ARBs also?
So I agree with you that the guidelines at present having the maximum evidence in favor of ARB, even it's a weak antihypertensive drug. The second best will be definitely is CCB, which are a strong antihypertensive drug. And nowadays, with a more than 180, preferably you start both the molecules together. The third choice of drug goes with the beta blocker if there is a resting tachycardia. We don't prefer hydrochlorothiazide or a diuretic like antihypertensive molecule unless with three blood pressure antihypertensive medication. If still blood pressure is not controlled, then we can think of putting them on a fourth drug, which will be diuretic. These are the patients they call ourselves a resistant hypertension. And then if it is not controlled, then we have to use the centrally acting and other molecules. But at present, the highest evidence is with ARB and ACE inhibitor to protect the cardiovascular problem in persons with diabetes.
Sure, sir. Next question that has come is, what is the role of prophylactic low dose aspirin? And in such patients with diabetes and hypertension, When do you think is the right time to start prophylactic aspirin?
No, so the prophylactic, there was a polypill trial which was done, their beta blocker and one AC inhibitor, one diuretic, and one statin, all were used. It had shown some decrease and it was all low dose, but massively you should not do. There is no point. I mean, it should be very much individualized. Why we should give like a packet to everyone that whether you are diabetic, blood pressure hai or nahi hai, you just take it. It's not like that. So now that concept of polypill, which has been originally introduced, like putting all these things in one and giving it to the all people with that. But definitely persons who are with metabolic syndrome, central obesity, the persons with diabetes, they should be screened more and they should find that if there is a chance their blood pressure, check them in twice. Sula ke bhi dekho, beta ke bhi dekho, and see that if their home blood pressure monitoring can be also done, that's very good.
Sure, sir. So the next question is, so what is the significance of nocturnal hypertension in patients with diabetes?
So the nocturnal hypertension is when blood pressure increases in night time. Normally it should get dipped. So
Right, sir.
when we are trying to monitor somebody who is pre-hypertensive, or when you want that who is at the higher risk, then we should do home blood pressure monitoring. So the first thing to go in a person with hypertension, which is starting, the dipping goes away first. And this nocturnal hypertension is again one more important thing is that increases the risk of cardiovascular disease, cerebrovascular accident. So in my clinical practice, definitely if home blood pressure monitoring is must. So they can measure early in the morning and late in evening also, and sometime midnight too. And if they have a risk of hypertension more, then we adjust the dose accordingly, then their blood pressure remain under good control in night time.
Right. So any drug preference that you have for nocturnal hypertension, or we just adjust the dose of the existing drugs?
So the existing drug definitely to be adjusted, increased. Long-acting molecules like calcium channel blocker we normally increase in the patient with this hypertension. But diuretic will work in the morning time, so that will take care of your morning up to 12. But definitely by decreasing the systolic blood pressure in morning time or daytime will definitely decrease the nocturnal hypertension also.
Sure, sir. So the next question that the audience is asking is, we know that beta blockers should be used only in certain cases of diabetes with hypertension. But according to your experience, have you seen bisoprolol or nebivolol or metoprolol? Anything better which is
I
compared?
feel bisoprolol and nebivolol better. But metoprolol sustained release is also good. And I do use very often because we have resting tachycardia is a major challenge for our patient.
So
Carbidiol is
bisoprolol,
also better with the intensing sympathetic mimetic activity.
right, sir. And then we have one more question, sir. Uh, you said that I think this has already been addressed. So you said that there are certain subset of patients in which we need to start treatment, even in with the lower BP thresholds.
Yes,
So
but
they
because they are
want
at
to.
high risk already, they are already obese, they are metabolic syndrome people, so they must be developing. So in between, if they don't want, then put them on ambulatory blood pressure monitor.
Right, sir. So ambulatory blood pressure. So when you say ambulatory blood pressure, just a sec. There was one more question hmm. Okay. So if there is a peak of hypertension in the early morning, which is the usual case, and the
No,
peak is
there's
more
not usual
than
case. If somebody having a peak of blood pressure early
right.
in the
Oh, sorry.
morning, they
It's
should
it would
go
be
and
not.
consult
Yeah.
the doctor.
Right. So this then we have already addressed this. So that should be you should need to adjust
Because
the
people
doses.
sometimes feel that occasionally मेरा blood pressure बढ़ता है. You know,
Right.
my blood pressure is most of the time under good control. When you check them, it's not. So, I mean, these are the people who should be pushed to ambulatory blood pressure monitor. It's really difficult to motivate the people, but it's really important.
Right, sir. So I think these are all the questions that we have in the chat box, and if there are any more, maybe we can address them later
Sure.
with them. So Dr. Gulshan will just give a closing statement for that.
Thank you, Dr. Manish. So with this, we come to the end of this very interactive and informative session. A big vote of thanks to Dr. Banshi Sabu for sparing his valuable time and being with us here today.
Thank
I'm
you.
sure the audience would have gained a lot from today's webinar. I would also like to thank our CME partners, Spirant Communication, for the smooth conducting of the program. And thanks to our audience. Take care, stay safe till we meet again. Thank you so much, sir.
Thank you.
Thank you. Thank you,
Yes.
sir.